think so.
Is it okay? Can you
Yep.
see?
Perfect. Thank you.
Thank you very much. Thank you for inviting me. Scott kindly invited me because he knows my interest in congenital hand. I came to Saudi from Canada maybe 30 years ago. I established the first hand clinic in Saudi Arabia, and I was lucky to collect all these rare congenital things since I was an early comer to Saudi Arabia. Um, Definition of mirror hand. Now, it's actually difficult to define mirror hand deformity because there are two entities. In the classic ulnar dimelia, there's usually 7 to 8 fingers with no thumbs, and the forearm will have 2 ulna. In the variants of mirror hand, the preaxial fingers will usually are not very well developed and may have also syndactyly, and the forearm may contain 1 ulna and 1 radius, and sometimes 3 bones, that is 2 ulnae and 1 radius. Of course, one of the ulnae will be hypoplastic. Now, I was lucky that in 1998, I thought to write a short paper to the British Journal of Hand Surgery at the time on the classification of mirror hand, multiple hand spectrum. Until now, this is the classification of mirror hand deformity that you find in textbooks, including Green's. Type 1 is the usual ulnar dimelia, as we said, multiple fingers, no thumb, and 2 ulna. Type 2 and 3 are intermediate forms where you also have multiple fingers, but the forearm may have variable variations, usually a radius and 1 or 2 ulna, and one of the ulna will be hypoplastic. Now, I classified type 4 as syndromic mirror hand, which will have all 4 limbs affected, mirror hands, mirror feet. And the most well-known syndrome is called Sandro syndrome. And I added to the spectrum type 5, multiple hand, where you will have duplicated hand with 2 thumbs and normal forearm bones. Now, epidemiology, we are actually talking about very, very rare entity. Non-syndromic is extremely rare, of course, sporadic and always unilateral. In syndromic, we just mentioned the Sandro syndrome. This is the number it carries in the genetics literature, extremely rare. You have bilateral ulnar dimelia, bilateral fibular dimelia with syndactyly of the digits. All patients will have nasal defects, and they are very characteristic. The patella is also absent, and it's autosomal dominant, and it's caused genetically by microduplications of the ZRS. Now, this is not ZPA. ZPA is zone present activity. We'll talk about embryology now. I'll tell you about what is ZRS. Now, what is the pathogenesis? Pathogenesis, I'm very much interested in pathogenesis of congenital hand anomalies. And with Scott, we wrote a couple of review articles of hand surgery regarding this. But for the mirror hand, if you take a cross-section of the limb bud, anterior means towards the thumb, posterior is towards the little finger. And you can see here the zone of prising activity, which is posterior, ZPA, contains sonic hedgehog. Now, the sonic hedgehog cells, carrying the protein, are the one in dark green here, this area. So these cells will have the sonic hedgehog protein, and then the protein diffuses out of the cells up to the index finger. Now, for the normal thumb to develop, you should not have any sonic hedgehog activity. So the protein carrying cells and the protein diffusing out of the cells would stop just short of the thumb. Now, the thumb will then be free to develop normally without the sonic hedgehog protein in place. And that is by many mesodermal factors like SAL4, HOX genes, and of course, the apical ectodermal ridge fibroblast growth factor 8 is essential for normal thumb development. For the thumb to develop normally, you should not have sonic hedgehog in that area, the anterior zone. Now, what happens if you gain activity of sonic hedgehog? The protein will start going further here. And once you reach this area with sonic hedgehog, the thumb says there's something wrong. You start getting thumb duplication, tripharyngeal thumb. And as you increase the activity, what happens is that the thumb becomes like a finger, and you start getting the five-fingered hand, as we said, or six-fingered hand, like a duplication of the index, most people will call it. Now, if the more you increase the sonic hedgehog activity anteriorly, the more you get more digits on the anterior side duplication-wise. So more preaxial polydactyly that look like fingers. I looked carefully into what happens. Why with the sonic hedgehog, like we said here, how can you increase this activity? This is not just more protein there per se. You have to have genetic background. If they look at the gene, this is the sonic hedgehog gene itself. Very far from it is what we call another gene, LMBR1 gene. It's situated in the 7q36. In the intron 5, you have something called what we call now ZRS. Z stands for zone of polarizing activity, R stands for regulatory, and S is segment. So this ZRS, zone of polarizing activity, regulatory segment, if you have a problem here, point mutation or duplication, it increases the activity of sonic hedgehog, as if this is kind of the inhibitor or the controller of sonic hedgehog. Once your controller goes wrong, sonic hedgehog goes out of hand and the activity is increased. And there are so many syndromes associated with ZRS problems, either point mutations, duplications, or micro duplications. So I wrote another paper, which I think is, summarizes my thinking about what I call the spectrum of preaxial polydactyly. It's published in the Annals of Plastic Surgery a few years ago. Now, like I said, minor anterior sonic hedgehog expression will lead to regular duplication of a thumb, bipharyngeal thumb. If you increase the sonic hedgehog further, you get the opposable tripharyngeal thumb, and also thumb polydactyly with tripharyngeal component, six-fingered hand. Moderate increase, even more, you get the duplications on the preaxial side with syndactyly. And then when you have more than that, you get what we call the variants of the mirror hand, so non-classic. Now, in order to get a true classic mirror hand, experimentally, you really have to have a problem with pre-patterning, as if you are putting another zone of present activity on the anterior side. So this pathogenesis of classic undermilia is actually different from all the other types, including the non-classic mirror hand. So I personally believe this paper is like 20 pages in the journal. I believe that the pathogenesis of non-classic anordymilia, which is the variance of mirror hand, is very, very different from the pathogenesis of the classic anordymilia, where you find the classic 7 fingers, complete mirror image, and 2 ulna in the forearm. So that's the idea of pathogenesis of the 2 main types of mirror hand deformities. Now, we all talk about fingers and ulnar, but you have to, the whole limb is abnormal. If you see a patient, you will realize this very quickly. The scapula have different variable deformities, but they always have a hypoplastic supraspinatus fossa. The shoulder will have variable degrees of glenoid hypoplasia with subluxation or even dislocation of the humeral head in some cases. The lower humerus on the elbow, obviously, no capitulum, true trochlear, which are frequently hypoplastic. And of course, that leads to limited elbow movements. The forearm, it's very interesting that the distal ulnae are usually broad, and the preaxial ulna is frequently short. And of course, forearm rotation is not possible because of this anatomy. And I found in my cases that the forearm is usually held in pronation, even though some authors said some forearms are held in supination. A wrist, this is, I think, a major problem in mirror hand. that is very little written on it in the literature, because the wrist you frequently find flexed with volar subluxation, and it's usually radially deviated. Why? Because the preaxial ulna is usually shorter than the post-axial ulna, and wrist is completely incongruent. I always splint these since birth in extension and then think what to do about them before 1 year of age. Anyway, but Carpus-wise, amazing symmetry around the central segment. What we call the central segment of mirror hand is very interesting because the central segment has two capitates in the distal carpal row, but each capitate will have a triangular defect proximally to accommodate a central pentagonal bone in the proximal carpal row. Now, on each side of the central segment, there will be a hamate, one hamate on each side in the distal row, and a tracheal pisiform on each side in the proximal row. Of course, we mentioned the hand 7 to 8 fingers. There may be a deep cleft in the center, which I think an important thing to realize, rarely mentioned in any textbook, and you will see why at the end of my presentation. And the preaxial digits, as I said, may be hypoplastic and may have syndactyly. Muscles and tendons are also interesting to know. Shoulder muscles, they will always have hypoplastic supraspinatus and deltoid, even though the other shoulder girdle muscles are usually fine. Arm muscles, the biceps is hypoplastic with a double triceps. Forearm flexor muscles, two flexor muscle masses separated by, on the edges, on the borders, by very well developed, thick flexor carpi ulnaris muscles. And of course, the FCR is absent. The FDS arises from the post-axial ulna and the FDP from both ulna. The forearm extensor muscles, I can have no explanation pathogenesis-wise. They are always hypoplastic to a variable degree, different from the flexor. And in fact, most of the anatomical dissections done showed that they end with thin fibrous bands in the dorsum of the hand. They are not truly extensor tendons, like in the sense that they are doing proper function. Now, in the hand, each finger will have two flexors. Like I said, flexor side is fine, but the extensors are severely hypoplastic. Specifically, lumbricals and the dorsal interossei are deficient to a variable degree. The vessels, to me, are extremely interesting. Cannot explain it because everything is more or less symmetric except the vessels. The forearm vessels are not symmetric. You have a brachial artery you start with, and then it will usually have a low division, and it will divide into one large ulnar artery medially and a smaller one. We call it in this case, because it's mirror hand, a small ulnar artery on the lateral side. And the courses of the two ulnar arteries in the forearm are asymmetric. That's why even though the textbooks, the dissections done call it small ulnar artery laterally, I think still this is a really a radial artery. So there is no symmetry of the vessels per se in the forearm. But the hand vessels are very different. They are very symmetric. The two arteries we mentioned before will enter the hand to form a very well-formed superficial arch. So this is a palmar arch, and that gives rise to common digital arteries, but the deep arch will be poorly developed and is formed by deep branch from these two arteries. So in the hand, the vessels are symmetric, but the course of the vessels in the forearm are not symmetric. Nerves are interesting. In the cubital fossa, you have a huge, large median artery, median nerve, accompanied by the brachial artery, and one ulnar nerve, which is interesting because it passes above the medial epicondyle, not behind. So now these are three nerves, and the large median nerve will go down now to the distal forearm to divide into two median nerves in the distal forearm, entering the hand through a carpal tunnel to supply the central fingers. And then the hand will have two ulnar nerves. One we mentioned before, the main ulnar nerve that goes above the medial epicondyle, which is, we call it the post-axial ulnar nerve, is in continuity of the main ulnar nerve of the forearm and supplies the ulnar digits. What about the fourth nerve? Is another small ulnar nerve. We call it the preaxial ulnar nerve. It's small and it arises from the superficial radial nerve dorsally. It comes from the dorsal branch. And since it's entering the volar aspect to supply the volar aspect of the most lateral finger, we call it the second ulnar nerve for the deformity. That is, so we can say the hand will have two ulnar nerves and two median nerves. The two median nerves is actually a division of the main median nerve. The post-axial ulnar nerve is the regular ulnar nerve, and the pre-axial ulnar nerve is a branch of the superficial radial nerve that supplies the most lateral finger. Now, surgically, you have to think of what to do with the elbow. Of course, you have limitation of forearm rotation, limitation of elbow movements because of that anatomy. And that's standard, and most of us will do the same. Excision of the proximal end of the preaxial ulna will improve movement and forearm rotation. Now, forearm osteotomy is only indicated if the forearm has a significant supination deformity. In my cases, as I said, I didn't have to do that because they were all in pronation. Wrist joint flexion deformity. I told you you have to splint all these kids since infancy, and then decide a few months later whether you need, if it's too tight, not responding to the splint initially, you don't hesitate. You take them and do volar wrist capsulotomy, lengthening of the two FCU tendons on the volar side if needed, and you do tendon transfer from the flexor side to the extensor side of the wrist. Still, late wrist fusion may be required in severe cases. Now, what is the surgical management in the hand? The key thing is to establish a new thumb with a good first web space. And I think first web space, good web space is, to me, is more important than thumb because you have so many digits. You have options of many thumbs to choose from. But if you don't have a good first web space, you don't have a good hand. The standard of care, all the textbooks, all the papers published, policization of a selected radial finger, and of course, you amputate the remaining radial fingers. I was lucky to see 6 cases. In 2 cases, what I do is I don't do policization, and that's my third contribution to this topic. I believe what I do, 2 cases had no deep cleft. Remember, I said in anatomy, you have some of them have a deep cleft in the mid palm. In the 2 cases that had no deep cleft in the fingers, I select a finger that is not next. So I select the finger so that I recreate first web space. And in the other 4 fingers, the deep cleft, the cleft will act as the adequate first web space that I want. In all 6 cases, one of the radial fingers is kept as a thumb without policization. And in 4 out of the 6 cases, of course, you will need to do secondary or primary. Sometimes I've done in 2 rotational osteotomy of the new thumb to put it into more pronation. And that's my paper on the topic, thumb reconstruction without formal policization in mirror hands. I'll just give you some examples. Look, this one of my cases, remember I said, these are the ulnar digits. They're always very well developed. 4. This one is lucky, has a cleft here. So, look at the incongruity of the wrist joint, but he's still managing very well. But look what I do. In here, I would just select one digits, amputate this, or keep this, and I decide, depending on, I test the function in the child, and decide just to keep one finger and then do osteotomy of the finger to bring it in more pronation. And you can see it's really good. Of course, this technique will leave this a bit longer than usual, than you do policization. But I think it being longer is good in many of these kids because the radial digits are not usually normal because they're a bit stiff. When they're a bit stiff, when it's a bit longer, the kid is using it better. Here's another one with a good cleft. So you can see here from my amputation, I amputated all these digits and kept this. Why I can afford to keep this? Because there's a good cleft here. And I did primary osteotomy, rotational osteotomy, and the kid was using the hand very well. Another case, now this case I'm showing because it's quite different from the other cases. in particular regarding, if you look at the palmar aspect, you can have here the classic and everything, but with the palmar aspect, the fingers are very short, the creases are not there, and look at the shoulder deformity. And I kept, of course, this is too close, so I did not keep this one. I kept this one as the thumb to create, and this space will be my first web space. Now, why I'm showing this is that people will say, okay, let's assess in my paper, I have full assessment of thumb function and hand function, but I'm telling you, it's not who's doing it, it's how good quality are these fingers and the remaining fingers that you are keeping using, whether for polymerization or keeping for osteotomy and as a new thumb. When you have poor intrinsics, short fingers, no much of flexor creases, they're not flexing very well, the function will be not very good, regardless of what you do, whether you do polymerization or you keep a thumb with a good web space and you do osteotomy on it. That's another case. Again, the same classic anadymilia, good web space, so I kept one, and it looks too long, but the patient is happy and using it very well. So in conclusion, the author has a personal series of 6 cases and 3 personal contributions to the topic. Number 1, the classification of the spectrum of the deformity bears the author's name. 2, embryology pathogenesis in the spectrum of radial polydactyly was described by the author. And 3, the introduction of a new option. I'm not saying it's the best option, but it's a new option of first web thumb reconstruction without formal polymerization in mirror hand deformity. Thank you very much.
Thank you, Mohammad. It's a fantastic experience. This is the sort of thing that most of us only see fairly rarely, and so it's wonderful to have someone who's really encountered a number of things and really had to think about it. Just with respect to some of the questions that have come up through the chat as we've been going, with respect to the elbow, the excision of the preaxial ulna, in your cases, did you do that in all of those cases? All 6?
No, in 3 only.
And
the reason is some in our institution, it depends where I work. In some hospitals, I deal distal to the elbow, so I deal with the wrist and hand only. Remember, my background is plastic surgery, but I do a lot of orthopedic. And in other institutions, this has to be referred to a pediatric orthopedic surgeon.
And so I've only seen one of these kids, and I haven't dealt with the elbow yet, but I was worried that by removing the preaxial elbow, preaxial proximal ulna, I was going to destabilize the elbow. Is that been your experience, or?
No, I don't. If the range of motion in flexion extension is acceptable, I don't do it. Right. I don't care much about recreation or improving forearm rotation. Since they are in a functional position, that's fine. But I think personally, indication for excision of that part of the ulna is only when there is too little movement of the elbow.
And have you done anything as a?
Yeah.
Sorry, have you done anything as an active flexoplasty? You said the biceps is deficient.
No. The bicep is deficient, but they have active elbow flexion.
Okay. Just going through the other. Scott, have you got a comment about the elbow there? I remember talking to you about this at a meeting once.
Yeah, so we have tried a bunch of things with the elbow, and sometimes removing the proximal ulna gives you some motion, and sometimes it gives you no motion. So we've even gone to the extreme of trying to do an elbow release, kind of like you do an arthrogryposis with the capsule and the VY, the triceps and the whole bit, and that also has been unreliable. I think sometimes it's just stiff, and we can't get it to move. We've had the same problem with the wrist. We've applied different techniques for the wrist that we do in arthrogryposis, like a closing dorsal wedge. We even put a Lisroff on some of the wrists. you can get too neutral, but you can't get what they really want, which is extension, because they want to wait there, and it's very difficult. I don't know if Dan has any comments. So I just can't seem to get the elbow back, or the elbow, I'm sorry, the wrist back, or the elbow bent. It's been frustrating.
I've got another question here about the lateral ulnar, presumably referring to the preaxial ulnar, gaining the morphological characteristics similar to a radius, both distally and proximally. Can I get your opinion on this? Have you seen that, Mohammed, or is that a...
No, yeah, but you see, remember, the distal ulnar shape has nothing to do with it will always, especially the distal part of the ulna on the preaxial side. You find as the kid gets older, it gets wider, as if it wants to become a radius. I'm not sure why, but proximally, this is how can I decide, is this dimelia or not? Because some of these kids are born with two ulna proximally, very, very much. You cannot miss it. It's just two ulna, but distally, one of them looks like a radius. And I think you decide this is an ulnar dimelia or not by examination of the two bones proximally and not distally.
David, can I ask Mohammed a question?
Sure.
Mohammed,
Cool.
Can you just take us through how you converse with the parents and the child with a mirror hand? What do you tell them is the cause? Like in just normal, obviously the whole ZPA, but what do you tell them?
Remember, first of all, I actually sit down and draw a diagram, then show them the x-rays of a normal, the same kid. I put two x-rays together, the normal limb and the abnormal limb, and they kind of understand better this way. And then I tell them, this is the little finger, ring finger, middle finger, index finger, and then we have no thumb, and we have to choose one of those to make a thumb. And we have other problems like shoulder and elbow and wrist and so on. And then they all kind of say, okay, how is the overall function going to be? The limb looks very odd. It's because of the wrist is flexed. So the first thing I do, I tell them the wrist is a big problem, but we'll put it in a splint and then see when are we going to do a few months later if we need to do surgery or not. And then we choose together which finger to keep. I tell them we're going to wait, depends on the age of the child, a little bit later, and then choose and describe to them the first web space. And then we go ahead. There was a paper in PRS Global Open, plastic surgery, on one group who had a mirror hand and they made a model for the parents. It was an interesting paper. And then they can change in that model and then show the parents' hand, how does it look after. This is an interesting paper published just within the last year in PRS Global Open. And then once this is done, most parents are much concerned about inheritance. So I tell them if it is unilateral, then it's sporadic, no need to do genetic analysis, and it's not inherited. The kids, when it grows older and gets more kids, they will be completely normal, and your other kids will be normal, then they are happy.
Thank you.
Thank you, Mohammed. That was a fantastic talk and great discussion. I think we've got to move on to our last speaker. Is that right, Zesko?